Good afternoon, everybody. Great to see you here all live after long months of not seeing real customers and real doctors. So great to see you here all. We're going to talk about, in the next 40 minutes, we're going to talk about non-invasive respiratory monitoring. Very exciting topic, new technologies. For me, it's important that we're going to discuss the concept of it, what does it bring to our patients, and how can we increase patient safety and also increase patient outcome. What are we going to discuss? We're going to talk about the journey through monitoring as such. What do we do at the moment? What did we invent over the last couple of years? And then also talking more about what does it mean, non-invasive respiratory monitoring. As well, what does it bring to our patients? What does it bring to you as clinicians? And then in the end, we are going to summarize it. And if there are some questions, then please keep them until the end of the session. First of all, we need to explain a little bit about the construction, how we are working here in the UK. We're going to talk about ExSpiron, the non-invasive respiratory monitor of respiratory motion, beautiful company out of the US. We are supporting them, and I'm working for Carevic Medical. We are supporting them to get international set up, and we are in the good position and the lucky position that we work in the UK with Pendulum as being our partner, who is supporting you as customers already from an anesthesia perspective, and we're going to expand that with non-invasive respiratory monitoring. Where did we come from if we are looking to non-invasive monitoring for all our patients on the ventilation and on the oxygenation side? In the early 70s, it started where we measured the first time the arterial blood gases, and over time that improved a lot in order to measure CO2, PO2 levels, as well getting a good understanding of the pH. Then afterwards we went to get more on the oxygenation side in measuring SpO2, where we're measuring saturated red blood cells, and that is basically a standard of care. Now I cannot imagine that there's a hospital anymore where we don't use SpO2 monitoring in order to make sure that our patients are well saturated from an oxygenation perspective. Then end-tidal CO2 came in a little bit later for most of the patients that are intubated to measure the exhaled amount of CO2. And then we made a little bit more steps to go to volumetric capnography, getting more understanding about dead space and also about the anatomic dead space, alveolary dead space, and the volumes of CO2. That was a big step. Also, respiratory rate as a good indicator of how good is my patient, how hard does it need to work, and it was integrated in a lot of monitoring systems on the hemodynamic monitors. Of course, we see still that there is a big step to make in terms of the alarming of it and the accuracy. And then now we are moving into the era of non-invasive respiratory monitoring. We see a trend moving on that we're going more to the non-invasive side of things. We try to treat our patients more non-invasive, not only from a ventilation, but also from a cardiac procedure understanding. And this time we will move to non-invasive respiratory monitoring, where we measure tidal volume, minute volume, respiratory rate on a non-invasive manner for all those patients that are not intubated, because that is at the moment still a big missing link. First of all, I go back a little bit to the basics of it, and for many of us this is daily practice. If we are looking to a patient from a respiratory performance perspective, we see two things. That's oxygenation and ventilation. And of course, the oxygenation makes sure that we have some oxygen to burn in our cells for the metabolism. And the gold standard to measure that is still the SpO2 monitoring. On the ventilation, on the oxygenation side, we need to exhale our carbon dioxide, which is being produced, and we measure that again over end-tidal CO2 or with a blood gas. To have oxygenation, we need to have open alveoli in order to get gas exchange going. We need to have a flow of oxygen and an inspired oxygen concentration. On the ventilation side, we measure, of course, with mechanical ventilation as well. We look to tidal volume, minute volume, respiratory rate, and the minute volume being a product out of tidal volume times respiratory rate. If we intubate a patient on your operating theater, on your intensive care ward or emergency department, you secure oxygenation by measuring SpO2, you give a certain amount of PEEP, positive index respiratory pressure, giving a mixture of oxygen, and making sure that your patient is well saturated, that you don't have any issues on that side. You make sure that you've got a good tidal volume, a good respiratory rate, and a good minute volume in order to keep your pH stable and to exhale the CO2 that the patient at that moment in time is producing. Tidal volumes can vary depending on the state of the patient that is having, according to AIDS guidelines, with small tidal volume deliveries, higher rates, but nevertheless we set those type of parameters and we also monitor them. The big missing link is what do we do for all those patients that we don't intubate? We still measure SpO2, we still look to the oxygenation side, but we don't monitor minute volume, tidal volume, and respiratory rate. Respiratory rate, need to be honest, of course everybody has it on their monitor. With the high amount of false alarming, that is not the ideal world we would like to see. That's why we are doing it in a slightly different manner and also showing that we don't make nurses getting alarm fatigue by just correct measurements. But this is the whole missing link. We have no clue about what we're doing on tidal volume delivery and minute volume as soon as we have no tube inside of a patient. Of course, on the non-invasive ventilation, we still get those parameters, but there's a high amount of leakage, and those monitoring parameters we get out of it are not always that reliable. This is where we are focusing on when we are talking about non-invasive respiratory monitoring. We apply a consumable, putting 3 stickers on the patient and measuring tidal volume, minute volume, respiratory rate for all your patients that are not intubated. How do we do that? Well, we apply the PET set, that's how we call it. We apply it on the right side of a patient, and most of the doctors now will ask, oh, what do you then do with your left side? Well, that's a really good and nice question, thank you very much. We're doing the right side and recalculate it to total lung capacity. There's a lot of literature and evidence out there that in normal circumstances, like we are sitting here hopefully today, is that 55% of our right lung is, that's 55% of total lung capacity. So we recalculate 45%. And one of the other important factors is that the trend data that gives us a good estimate about how this patient is developing or decreasing and deteriorating in tidal volume and or minute volume. The technology that we've been basing this on is, and it's not for us, it's a new technology. In the UK we did not see this so far. In the US we are running since 2014 with it, but being a US company, sometimes we've not always been looking to the countries outside, and we are now in the lucky position that we can. So we measure it on impedance, biological impedance, and biological impedance is not something new. There are multiple manufacturers also here present that are moving to the electrical impedance tomography world, and we are basically using the same technology, which is biological impedance measurement, and based on the differences in impedance, differences in tissue. So non-aerated tissue is giving you a different current than aerated tissue, and based on that we can make sure that the tidal volumes and the minute volumes are correctly done. This is how we do it. So with putting 3 stickers on a patient, making sure that they are secured on a good tidal volume, minute volume, and respiratory rate monitoring. The false alarms, that's a big point. If you as a doctor, if you're getting out of your 10 alarms, or you as a nurse getting out of your 10 alarms, getting 9 alarms that are not accurate, that are false, What does that do with your willingness to go for the 10th time? Or what is your mindset if you are going for the 10th time? There's a lot of studies done on that. We come to that a little bit later during the presentation as well. Why is this important? Why all of a sudden now in 2020 do we make the step to non-invasive respiratory monitoring? The importance is within your patient, and we call it the rule of 71 minutes. As soon as your patient is getting acute respiratory failure, needs to increase his work of breathing, does not get enough support in order to maintain his normal ventilation, he will get into fatigue. If you know what is happening from a tidal volume, minute volume perspective, you could adjust your therapy. You see that your tidal volumes are going down, they are decreasing, minute volume is decreasing, so you need to give a little bit more high flow, or you're moving to non-invasive ventilation, or even you're saying, this patient is not going to make it, we're going in the early phase, we're going over to intubate. So the 71 minutes is crucial, because up to today, what we are doing, we're still measuring SpO2, we're still sitting on the oxygenation side, and we are basically with the SpO2 monitoring the ventilation side. We can optimize that, and of course that is not something that is completely new. There's also multiple studies done about the mechanisms, and that we are really late if we see that SpO2 is dropping. First signs of higher work of breathing, of lower tidal volume within your patients, you could earlier detect by measuring them. And waiting on the SpO2 side, you lose 71 minutes. And this 71 minutes, that is what is coming as a minimum out of all the literature. Talking to multiple doctors over the last couple of months, some say, yeah, I see it already a day before, some say I see it already much earlier. What we have from an evidence perspective is 71 minutes. That 71 minutes enabling you to optimize your therapy, or to switch your therapy, or to say, we're not going to make it, we're going to intubate. You have the time to inform your patient, you have the time to inform the family, and you don't need to go to the stage where your patient is completely fatigued. And by having that complete fatigue, you give them some propofol, you're going to intubate them, and gone is your blood pressure. So not only on the respiratory side of things, but also on the hemodynamic side, there are steps to make with early decision making as well as early monitoring. That is 71 minutes. From my side, you can forget everything about this. If you keep 71 minutes in your head, that's the most important, because that is giving us that we can treat our patients better, faster, and more accurate. From a company perspective is that we've been looking a lot, what is important for you doctors and nurses, what do we need to bring to new technology, what is important that you can use it every day, that it's for all your patients available. So there are some key factors in that, and they are just in a random order. Of course, patient care and patient safety is number one. Ease of use, plug and play. You don't need to have a lot of support in starting it up. If everybody who can read where they need to position it, can plug and play and start, and that's it. Over the next couple of points, we will show the next slides. Where do we use it? And we are in the lucky position that in the US we're using it already since the last 6 years, and have a lot of experience there. And we see that we're using it on the emergency department for triage, to see if somebody's already getting into acute respiratory failure, and can also actively get them into a therapy. Another part is the anesthesia. Procedural sedation, all those patients that are getting an epidural, or who are having a little bit of higher BMI, having some form of COPD, where you know this is somebody where I need to be careful with. All those patients, we tend to work with non-invasive respiratory monitoring. Not intubating, an epidural, or short-term procedures. As well, post-anesthesia on the recovery room, On the recovery room, we missed a lot of ventilatory depressions, and just by not measuring it. And so far, we've never been able to measure it. That's going to change. On the intensive care, if we're doing TPs trials and want to make sure that our patient is maintaining their own effort on tidal volume, minute volume, that we can now start monitoring it, as well as in the pre-phase. And we see the influx of, for instance, high flow come a little bit later to that, but that's a massive thing. And the missing link, again, is tidal volume, minute volume delivery. We want to do a correct setting of high flow, but we need to have some sort of output from our patient in order to apply the correct settings. Then the general care wards. For some, they will say, I don't want to have any technology moving further to the general care wards, because perhaps we're going to shift the sicker patients more to the general care ward. We see it more as a matter of increasing safety. If on the general ward we're having some COPD patients or some patients that are asthmatic or with a high BMI, or just patients at risk for respiratory failure, and the alarm goes off, because of that there are no false alarms. If an alarm goes off, you know you need to call the doctor. And that's an early warning mechanism. We don't want that on the general ward. We want to increase the workload, because the workload is more than enough, and we should basically work on decreasing the workload. That's what we're going to do with early warning systems, that we don't need to come into a situation where all of a sudden we need to run to the ICU with the patient. They need to come and intubate your patient at the last moment. As well as for pain management, making sure that from a breathing perspective, your patient is breathing correctly and that it's also being supported correctly. Another point is what is important. It is important that it's accurate, that you can rely on it in a 100% manner, that you know those numbers that we see, the tidal volume, what my patient is breathing is correct. And due to the many studies that are done, as well for the FDA approval, as for the CE marking, as well in all the other studies, we've shown that it is highly accurate. So this is making our life in the hospital a little bit easier. We have been talking about the 71 minutes. This is just an example about, and there are 40 and more studies available about non-invasive respiratory monitoring in the meantime. This is also showing if we are measuring SpO2 and looking to ventilation, those two do not 100% match. And there's a big time delay, so we need to monitor non-invasively tidal volume, minute volume. On the anesthesia, this is another example about how it works on the anesthesia, and the recovery rooms, that indeed we detect in a much earlier phase if there is some respiratory distress. And by doing that, we can adjust therapies, or we can earlier support the patient, as well earlier discharge. So it's for everybody, and for the main thing for the patient, it's the best thing to do. I've been talking a little bit about false alarms, and that's not something that we came up with. That's been studied rather well. This is a study with, for instance, 250 subjects, where we used entitled CO2, SpO2, and looked also to the reliability of the alarms that we present, and that seems to be spot on. And it is not that it needs to be that I want to highlight that we're doing a better thing with alarming. It is more about a prevention of alarm fatigue at nurses and doctors. And I think that is a crucial and really important point if we are talking about patient safety. If you're getting an alarm, you should be, which you're setting yourself, you should be 100% sure that at this moment in time, there is something happening with your patient and they need to have your attention. On the cost side, and we are, of course, with the payers, and also here with the NHS, we are also looking to the cost of things. Where are we? We see that from a general ward that there are within 12 hours, 60% of the patients, they show some sort of decrease in or cardiac functioning, neurological functioning, or respiratory functioning. From those 60%, 50% is on the respiratory side, which is massive. And by detecting it early, we could prevent that we're getting into this stage and need to transfer them to an ICU. We spoke a little bit about high flow nasal cannula. It's one of the trends, also accelerated by high flow. Also accelerated by COVID, unfortunately, where there's been a shortage of mechanical ventilators in a big population of the world, where we've been looking how can we support patients nevertheless who need the support with some additional oxygen and some additional pressure, and high flow nasal cannula went off even more than it already did. That is also shown in some other studies where they investigated the market and what do we expect for the future. We're moving more towards non-invasive support, and let's be honest, high flow nasal cannula is an easy manner of supporting our patients, and it's well accepted by them in many disease states for that patient. But still, if we look into a high flow nasal cannula, we are measuring SpO2. We are measuring SpO2 for oxygenation and ventilation. And I think we just agreed on we need to also look to the ventilation side of things. So this is a missing link. And how easy could we optimize the usage and also the safety of those patients by applying monitoring of tidal volume and minute volume for those patients. So for us, this is a big thing where we are putting a lot of effort in to make sure that the high flow, also from a setting perspective, because when are you going to use 40 liters? When are you using 30? When 60? When 70? I don't have all the answers for every patient that we're seeing, but if we can make something like a protocolized standard of care by monitoring tidal volumes, knowing the output of the therapy that we started, we are on the front side and we can support patients in a better manner. So how does it look into summary? We see that mortality rates are high, based also on respiratory depression. What could be an answer? An answer definitely on the respiratory side could be the monitoring of minute volume, tidal volume, and respiratory rate. Also in other settings, when we need to go to the ICU, for instance, we see that mortality rates are increasing by not using it, and also the cost factor is high. If we see that, 29 to 1 patients, we basically could get into a safer place by starting to monitor tidal volume and minute volume. If you're working on the anesthesia and on the operating theaters, what do we see, and what do our customers basically see? What do your fellow doctors see as a big advantage? That you get real-time data on how your patient is doing, and the early warning and increasing patient safety. I think that is the key thing where we are looking for if we want to treat our patients in a different manner than we do them today. If they're moving further to the recovery room, we also would like to have them quickly discharged. The influx on the recovery rooms usually is high. There's a high turnover on patients, and it's an important factor for the hospital to get their funding in. So people should not be that long on a recovery room. If we can monitor them in the correct way, literature has shown that we also can move them further in a safe manner to the regular ward. That's of course what is important. For the general ward, most important thing is increasing patient safety. When on the general ward a patient is getting into respiratory distress and there's an alarm, we know something is happening, perhaps the doctor needs to have a look, or one of the colleagues need to have a look. We don't want to shift the weight to the regular ward, we just want to increase patient safety. For the ICU, of course, it's making decision making easier. How do we use technologies like high flow? When are we going to intubate? How do we prevent the respiratory failure? How do we prevent also the hemodynamic effects of fatigue on the respiratory side? As well as, do we need to re-intubate, or can we already extubate this patient? How do they work on the TP's trial? Can they maintain their own work of breathing? So long story short, 71 minutes. 71 minutes is the most important. We want to decouple monitoring from the oxygenation and the ventilation side. Just be early and prevent harm, and that's where we all signed up for, I think. So no false alarmings. If there is something, we need to have a look because there is something happening with your patient. And there is so much evidence available already. I'm more than happy to share with you if you are eager to read something more about it. We got something like 40 large studies done at the moment. We're working with Professor Gattinoni, with Ciumello, Bilani, and Fotti in Italy to get also on the ICU, get more data available, and that will come shortly. So most important thing, 71 minutes, early detection, increased safety, and on the back of that also reduced cost for the hospital. If you want to hear anything more, because it doesn't stop after this 40 minutes, we are here luckily for the next 2 days. If you want to share your experience or want to have a talk about non-invasive respiratory monitoring, or you want to have some further literature, please come by. We will have a lot of materials available. I'm more than happy then to share it with you and to spread the message in order to increase patient safety and increase our patient outcomes. And that, looking forward to meet you there. And if you have any questions, then please feel free to ask them.